Hello, Kat. Welcome to class PHR209. We'll be meeting Mondays and Wednesdays, as I said in my email. And you need to go ahead and make sure you get on each Monday night as soon as you can after work. There's just no way I can do a Tuesday or a Thursday. So we will be meeting Monday and Wednesday and I know you have that you can do that on Wednesdays. We did that a couple of mods ago when I was helping you with COM 103. So this is probably your last pharmacy class before you do your capstone. I think that's what you're going into next mod. So you're getting close. So we need to get through this class, and this is called Pharmacy Technology Applications, and we're going to be looking at a number of things. First is you're going to be reading in your textbook. The textbook is available online, which you can access, and you'll be reading some chapters each week. Chapter 5, we're going to go through tonight. 10 is about medication and food and drug interactions. And chapter 31 is financial issues in running a pharmacy. So we'll go through all of those. There's a discussion. We'll talk about that as well. And you have an assignment. Your assignments will contain, you'll be able to use the workbook, and we should be able to get the workbook pages for each week. So you're going to download these pages, and then this is what they will look like. It's a PDF, and we'll open that. I think that's going to show. We'll find out. It's being slow. Here we go. Okay. So we'll bring that up and look at it. That's what it will look like. Okay. This is what it will look like. Let's enlarge it so we can read it. So there will be a series of questions, the workbooks, starting with some information that you'll be looking at to do with dosage forms and that sort of thing. And then a bunch of questions. So the questions you will use, it will answer, and they will be related to a quiz that you will do later. So you'll need to get this downloaded and printed and go from there. Let's go back to here. So there's one for each chapter, and it tells you which of the pages you should be going through. And then you have an assessment each week as well. The assessments should be set up so that you can take them multiple times. Let's just make sure of that. No, I will be changing that, and you will be able to take the assessments multiple times. So because I want you to learn the material. There will be no time limit. You'll get 3 tries. So so we'll have that as part of your work as well. So so this week we're going to start off looking at chapter 5. Let's see if we can bring that up. Hmm. It's not working, so we're going to do it this way. Um, so we're going to go through this. Dosage forms and routes of administration. These are related concepts. Um, the route of administration tells us what kinds of dosage forms can be used. The dosage forms themselves give us a clue as to the route of administration. Um, some drugs, obviously, you can't crush up a tablet and inject it. That's not, they're not sterile. We know that anything that's injected is sterile. Um, we can inhale, we can put drops in eyes and ears. Those are also sterile. So it also depends on the drug, the purpose, and then, of course, the route of administration. So let's go through this. Um, let's see if I can do this here. Good. All right, so now I'm in full screen mode. And let's try this. Okay, so we're going to look at sources and medication errors, dosage forms, and drug administration and methodologies. Drug sources have, until the late 19th century and really into the 20th century, most of our drugs came from the world of nature. They either came from plants or directly from animals, um, or they were ground up minerals. And we still do all of those. Um, not so much animals anymore, even though they're saying here, including humans. Few products now are isolated from people because we've had problems with diseases being transferred, like AIDS, being transferred that way. So we don't have a lot of animal sources. Plants, a lot of plants. We still have drugs that we isolate from plants because we don't know really how to manufacture them in a way that is cost effective. The most common is probably digoxin, um, which is for congestive heart failure. It's a very, very potent drug, as many plant-based drugs are extremely potent. Um, and that's probably one of the most common plant-derived products that we have. Animals, if we include um, um, in that definition things like fungi and that sort of thing, which are also plants, but we also have products that are derived from small living organisms and bacteria. Um, plants, fungi are also a source of antibiotics. So we have a number of these products. Minerals, we still take it. If people have anemia, they take iron. That's a mineral. Um, we often take calcium and zinc and magnesium and other things as supplements, but nonetheless, they are an important part of our world of drugs. So synthetic chemicals, these are most of what we see these days. We mostly manufacture products in a chemical manufacturing plant, and then prepare them, formulate them into drugs, and we'll talk about what that means shortly. Bioengineered or genetically engineered drugs, these are becoming more commonplace. Many of the newest drugs that have come out, and many very, very, very expensive drugs that have come out in recent years have been the product of genetically or biotechnology engineered drugs. These are often grown in cells and isolated from cells. The cells range everywhere from bacteria to human cells. So depending on the drug, we have a wide range of these things. Said that digitalis, this is digoxin, comes from the foxglove. We've got salt, iron, etc. Some very potent enzymes and hormones can be isolated from animals. More and more, at least in our part of the world, we are using bioengineered cell lines to produce these things in a much purer form and in a form that is free from infectious agents. So, because we had a number of problems over the years with patients coming down with HIV as a result of human-derived drugs. Synthetic drugs include most everything. Some of the newer forms of insulin come from genetic engineering as well. Dosage forms range from gases to solids. We have gases, we have liquids, we have semi-solids, and we have solids. We're not going to play a lot of time with gaseous drugs, but think of inhaled anesthesia as an example of a gaseous drug. But the most common medicinal gas is actually oxygen. There are lots and lots of forms of solid drugs, tablets, and there are many different forms of tablets. Chewable, sublingual, which means under the tongue, enteric coated, which means that they only will dissolve after they have passed through the stomach and gone into the small bowel. Plasters, these are an old form where you take liquid and powder and put them on and let them dry like cement. Capsules are common. They're usually gelatin. They're often used when with medications that have an unpleasant odor or taste, and they're often used when we want the drug to be powdered when it's released in the stomach. We have sustained release, timed release capsules, which means that they release drugs slowly over time. And then we have something that's shaped like a capsule but is a tablet. We call it a caplet. Gel caps, very commonly seen in things like vitamin E, vitamin D, vitamin A, a few fat-soluble drugs that generally are harder to get in. We have powders. We have, in fact, we still sell some drugs in powder form where you tear open the packet, drop it into water. The granules is just another piece of size issue. It's larger chunks than a powder, but smaller than a crystal. So, in other words, a big range. Troches and lozenges, these are used for local mouth and throat application. A lot of them are held buccally, which means between the cheek and the gum, and let to dissolve. Here's a picture of some of them. A comment here is that every single one of these, even if they look very similar, are different in some aspect. This is a range of possibilities, but it's not not the full set. We can have scored tablets designed to be cut into pieces. They can be scored into multiple pieces, thirds, fourths, eighths, etc. Most things are not past fourths, so that we don't have to do that. But you'll notice that some of them have writing on them. Others have embossed lettering as well. We have different colors, we have different shapes, we have different sizes. All of these can be used to identify a drug that somebody brings in and says, I don't know why Granny was taking this, but here's her pills and hands you a baggie full of a dozen different kind of pill. So we can use these pictures, what they look like. And we saw that in COM 103. We saw pictures of some drugs. Um, each one is unique. Even if they have the same color, the same shape, the same size, there will be something on it, a number embossed into it, a symbol, or something that would allow someone who had the key to identify it. Here we have coated tablets and caplets. Um, the coating is designed to make them easier to swallow and in many cases go through the stomach and then dissolve in the small bowel. Capsules can be monochromatic or they can have bicolors. They can have bands around the middle. Um, the They can be clear. Often when they're clear, you look at them and you'll see multiple different colors of pellets in there. These are generally sustained release products. Each pellet will dissolve at a different rate. And then here we have gel caps. These are gelatin capsules that can't contain an oil-based material. Even though we can't see the difference between these two, if they're different drugs, there will be a marking on it that will make it different. Semi-solids are just that. They're not hard. They're not necessarily at room temperature um, pliable or squishable or anything else, um, but but they can be. We have suppositories, which can be inserted into rectum or vagina. Some drugs into the urethra, but that is a specialty process. Ointments are greasy medications for external application. We rub them onto the skin, and then we usually want to cover that skin so that we're not getting the grease on our clothing. Other semi-solids are creams, which are water-based um, and um, and they're a mix of water and oil. Creams tend to be a little more oily than watery. They can be applied to the skin or administered by other ways. Gels are, again, jelly-like substances. One of the most common is the product BioFreeze that we used for aching muscles. We rub that on. It smells strongly of kind of mint or menthol, rather. And it causes, excuse me, a bit of a local inflammatory response in order to get blood flowing into an area that needs repair. Lotions are, again, they are mixes of oil and water, but they tend to be dry when they go on. Pastes and patches, okay. Pastes, again, these are topical and often with some form of fatty material that's used to take a drug across the skin barrier. Patches are something we've seen a lot of. Patches have been around since the 1960s, and there are many, many different designs. Basically, they go on to the skin and they stay anywhere from an hour to 3 days and then are changed. And if we put another one on, they have to be moved to a different part of the skin because the skin does not like to be occluded. It likes to be able to breathe. So it actually will die if you just leave things like that on. Liquids, there are many. We have syrups, which are basically sugar water with which can have a medication added. Syrups are easy to confuse with the kinds of things that like we put on pancakes. Um, but a medicinal syrup is a thick, sweet liquid that has a drug in it. Solutions are are drugs that are completely dissolved in whatever the liquid is, generally water, but it doesn't have to be. But for the most part, it's water or a water base. Spirits contain alcohol that is used. We used to use alcohol quite a bit as a way of extracting drugs from plants, for instance. Other liquid drugs include elixirs, which have a whole bunch of stuff: sugar, alcohol, water, etc. Um, Tinctures, which are um, alcohol preps of solutions of drugs, usually taken in small amounts. What we call fluid extracts are um, concentrated uh, sections of drugs that are taken extracted from plant sources. The um, the uh, the process for doing that is often a beginning process for coming down with a powder like digoxin. Liniments, mixtures of drugs with oil, soap, water, or alcohol. These clearly are only topical. We wouldn't be drinking things with soap and alcohol in them. That would be pretty silly. Liquid drugs, mixtures and suspensions. Um, Agents, these are drugs that do not fully dissolve in water or in whatever we're delivering it in. Uh, they require shaking, vigorous shaking before use. They should always, in a pharmacy, have a label that says shake before using, because they'll settle out. And then you have a layer of liquid that has very little drug, and then you have a layer of mud in the bottom, which has all the drug. So we shake them thoroughly before we use them. The Not too many drugs come as aromatic waters, but sometimes they're used in naturopathy. Um, and But this is distilled water and something that is an oily substance that will evaporate readily if it's just on its own. So, and these things have a distinct fragrance to them. Emulsions are um, mixtures of liquids that do not mix together normally. For instance, oil and water. Um, once it's shaken up and the oil droplets are dispersed, if it's stabilized, then it will remain in that sort of suspended state where you have either oil or water suspended in the other agent, and they contain a drug. Um, the thing is that most creams and lotions are emulsions. We know they're emulsions because they're not transparent. So liquid dosage forms, we'll talk about those. Sprays and aerosols. Sprays, often things like nasal sprays and that sort of thing, or fine powders, can be sprayed into a fine mist for inhalation. These are often used for um, asthma, and we spray things onto our skin as well. We can spray on Benadryl, for instance, if we are and calamine if we are exposed to something like poison ivy. Many of these things are liquids, but we have powders that are so fine that the particles can pass through the apparatus, and we do have dry powder inhalers (DPIs) that are used for a number of places, such as asthma and other bronchial diseases. We won't go into anesthetic gases. Okay, I'm going to take a short break. So I'm going to pause this for a moment. Okay, let's go on. Routes. So now we've looked at dosage forms. I said that the dosage form predicts the routes. Many of the semi-solids, the lotions, creams, liniments, and so forth, those are obviously just given topically. We don't drink those. We don't ingest them in any way. We certainly don't inject them. Nor, by the way, do we inject anything like cleaning solution. But many of the determining factors for the route have to do with the drug itself and the action of the medication on the body. Some drugs can only be given orally, or should only be given orally. Some drugs can only be given by injection. A good example of injectable only drugs is insulin. Insulin is a protein. It originally was marketed after isolation from pigs, and because the insulin that are produced by higher mammals, and pigs are a higher mammal, believe it or not, and are identical with human insulin. So it works perfectly well in the human being. But since it's a protein, you cannot swallow it. It will be destroyed in the stomach. I saw a demonstration many years ago of an insulin dry powder inhaler, because the lungs, inhalation of drugs is a very, very efficient way for drugs to get into the body, because the lungs are used to exchanging things across the alveolar membranes. So we know that we can get a lot of drugs into the body. So a company actually invented an insulin dry powder inhaler, and I never saw it get to market. So I don't know if it failed or what, but this was 35 years ago. So I would bet that it just failed. Characteristics of the drug. Other drugs that we take by specific routes. A good one would be nitroglycerin for angina. Angina is a heart condition where the blood flow through coronary arteries is restricted, but not necessarily blocked. But the restricted blood flow is extremely painful. There are several different levels of angina. Many people who suffer from angina will carry little bottles of nitroglycerin, and this is one of the few drugs that we dispense in the original packaging, which is a small screw top jar, because the last thing in the world you want when you're having what you think is possibly a heart attack is to try and open a child-resistant container. You just can't do it. So the nitroglycerin is taken, but it can't be swallowed because nitroglycerin is destroyed in the stomach. And I'll get back to another reason for that in a bit. The nitroglycerin then is actually placed under the tongue because the mucosal tissue in around the area of the mouth is very permeable and will absorb drugs rapidly. So nitroglycerin tablet, which is a little bitty thing, gets put under the tongue and it immediately disintegrates and releases the drug. So that's a characteristic of the drug that has predicted that. Another, drugs for nausea are often given as suppositories, for the simple reason that if you tell someone, swallow this anti-nausea drug, they're likely to just throw it back up. So it doesn't do you any good. So what we want to do is have the patient get the benefit of the drug. And again, These are generally rectal suppositories. The rectal tissue is also um, quite permeable and allows rapid absorption of drug in circulation. Age of the patient. Some people and their disease um, condition um, also will predict what route of administration you're going to give. If someone is, for instance, unable to take anything by mouth, we're not going to give them drugs by mouth. We're going to find another route. Many drugs can be delivered by multiple different means, including injection, topical, or oral. We'll get to absorption, distribution, metabolism, and elimination in a little bit when we talk about pharmacokinetics. The oral route is generally considered the safest and most convenient. Um, the the rate of absorption. What happens when we take a drug orally? It goes into the stomach, and the first thing it does is disintegrate the oral form. The gelatin capsule dissolves and releases its powdery contents, or the tablet um, just gets just slowly disintegrates in as it is attacked by stomach fluids, um, and um, and then the first thing that happens when you take an oral drug is it will go through the liver, where it will be partially metabolized before putting back into the circulation to be sent to its route or to its location of action. So the the time it may be the safest because you're not penetrating the skin, you're not shoving something into a body orifice that doesn't belong there, or anything else. It's safer to use the oral route. It's also convenient. You don't have to. We follow clean technique, and you remember that from asepsis. We follow clean technique, but we don't have to use sterile technique. So the oral route is that. It's also slow. It's at least a half an hour for most drugs before they begin to take effect at all. And you have to use more drug. Excuse me. You have to use more drug than if you injected it or by other routes, because um, the liver destroys a good portion of it. Anywhere from 20 to 80% of an oral dose is destroyed by the liver in what we call first pass metabolism, which then means that our amount of drug that we're giving people um, is higher than it would be if we were using a different route. Now, this is where you come in. You probably have seen this where you work. We use the basic equipment is the medicine cup or a medicine dropper or a calibrated spoon. Um, and that's when we are giving. When a person's taking their own, they simply pour them into their hand. But we never physically touch our patient's medication. The sublingual route I mentioned with nitroglycerin is much quicker, um, and usually within a few minutes you'll start seeing some effect. Because what happens is when the drug is absorbed across the mucosal membrane of the mouth, either by sublingual or buccal administration, buccal is between cheek and gum, um, it goes directly into the bloodstream. So you can get away with smaller doses of drug. Our tools, well, we've got droppers and we've got the little medicine cups and we've got spoons and we've got calibrated spoons and we have oral syringes. you'll note in this picture that this syringe has no needle on it. And we use this a lot for pediatric and some animal dosing, but it can also be used in an adult. This is a picture, don't you love the cavities? Picture of a sublingual dose. That is probably a migraine med. So it's there. The parenteral route is what we call anything that goes um, into the body other than through the digestive system. There's some argument that that only swallowed drugs would fall into the oral route or the GI tract, but we're not going to get into that. The administration of these through of drugs anyway, then straight through the digestive system is because the drugs bypass the GI. Um, we have basic equipment, might include needles and syringes. The drug would come in ampules or vials. They can be solutions, they can be powders that need to be reconstituted, and others. When I was a kid, we had reusable syringes. And so they would use a syringe and change the needle, and it would be, and that old needle would be sterilized and reused. The problem with that was that on multiple uses, it got duller and duller, and pretty soon it was like trying to shove a fire hose into your arm. You've already seen this. I'll just remind you. Needle gauge is the diameter of the opening of the at the tip, the beveled tip of the needle. The needle is sharpened, beveled to a very sharp point. Needles are manufactured in an interesting way. They actually start off as very long, what we call cannulas. They're very long stainless steel cylinders, thin walled, very uniformly made. And then they're sliced at an angle and thoroughly polished and buffed. And then they're sterilized and then coated with a solution, a silicone type solution, and allowed to dry. And the silicone actually just makes things a lot easier on skin penetration. So that's what we do with those things. The gauge is an inverted scale. The higher the gauge, the narrower the needle, the thinner the needle. This says it ranges from 13 to 31. Some of the insulin injector pens will use a 32 gauge needle. The 30 and 31 gauge, and then the 32 gauge pen injectors, those needles are pretty easy to bend, and so we have to be careful when using them. Lengths range from very short, basically 3/8 of an inch, which isn't very much at all, to 2 inches. So 2 inches is very long. It's used for certain deep intramuscular uh, and not generally the arm, although it can be. When I was in basic training, we had to get a bubonic plague shot because this was during the Vietnam War, and they were sending a lot of guys over to an area of the world where plague was still a problem. And one of the shots, most of them were given by injector guns. But one day we walked up, and there's these guys with these needles that looked like when they were going to stick right through you if they put them into your arm. They were 2-inch needles, and they were driven in the entire length because the vaccine for bubonic plague had to be a deep intramuscular injection so that it would be more slowly absorbed. The needles themselves, three parts. We've got the hub, we have the needle, okay? And at the end here, we have the slanted part called the bevel. We have reusable and disposable. Disposables were actually invented by a New Zealand pharmacist in the early 1950s. Um, and they have really taken the medical world by storm. Why we want to use them is that reusing needles carries a risk. First off, reusing needles requires sterilization. So right away, we can't use plastic, which is what the disposables are made of. And we can't, and glass is is actually a good material, but it needs careful washing and sterilization using an autoclave. Um, the syringe sizes actually are smaller than 0.5. Some of the insulin syringes are as little as 3/10 of a milliliter or cc. Mostly we use 1, 3, and 5 cc syringes. The most common actually is 3. Most injection volumes are low, um, simply because we're putting a lot of material into tissue, and we're creating a big bubble of liquid. And that's destructive to muscles and to adipose tissue for subcutaneous injection. So we try to keep things low. Um, there used to be some very massive injections given. Um, the um, the Before the hepatitis B vaccine, if a patient was exposed or a healthcare worker was exposed, they would go down to the clinic and get a 5 milliliter injection of hepatitis B immune globulin in the gluteus maximus, and then they wouldn't sit down for the rest of the day because it was extremely painful. Nurses were some of the happiest people on the planet when we finally had a Hep B vaccine. In fact, um, we have lots and lots of designs of syringes. Um, the most common is just a, a hypodermic syringe or that's used for subcutaneous and intramuscular. Intramuscular into the muscles, subcutaneous into the adipose tissue layer between the dermal layer and the muscle layer. They often use, most places now require that we use needles um, that have protection, that can be covered up at the end of at the end of a use, whether that is, and you remember from your uh, phlebotomy class, there was a little wing that would flip over the needle when you got done drawing blood. Well, most hypodermic syringes will have that or a variation of it. And there are numerous, including some really slick designs, where you inject the patient with the drug. When you pull the needle out, you push the plunger um, down hard again, and the needle automatically retracts into the barrel of the syringe. Um, it's scary the first time you see it because you see this needle disappear and you wonder if it's flying around the room. I used to scare students that way when I was teaching the injections class, or when I was teaching actually asepsis. I would demonstrate all of those syringes to try and get them used to looking at these different and using these different kinds of devices, different needle shields, different mechanisms for protecting from um, needle sticks. Um, Retractable needles are not uncommon for auto-injector devices. Um, and So, and I've used some of those when I was in the Army. I was working on a research post with nerve gases, and we had to carry an anti-nerve agent um, pen, auto injector with us. Insulin syringes are special. They're calibrated in units. Um, and for diabetes, for diabetics, because diabetics generally calculate a number of units. The syringes are graduated in units. The nice part of that is that um, insulin comes in concentrations of 100 units per milliliter. So the zero 0.3, zero 0.5, and 1 cc syringes are graduated in 1/100th of milliliters, which means they're actually graduated for diabetic use in 1 unit uh, um, um, demarcations. So if they need 15 units, they'll draw up 15/100ths of a cc, or if it's marked in units, they'll draw it up to the 15 unit. We have tuberculin syringes um, that we use for intradermal injection, which means between the cutaneous and subcutaneous layer. You saw that in pharmacy 107, your injections class. Um, Many drugs, including a lot of vaccines these days, come as pre-filled syringes, single dose. It's used once and discarded, um, even if not all of the contents are used. But many of them have to be drawn up out of a container. We have ampules, which are sealed glass containers. They either hold a single dose or they're just for a single use. And they range in size from, I think, from about a half a cc up to 60 cc's, depending on what they're being used for. Vials are bottles with rubber stoppers. You saw that in your injection class. We had vials of sterile water for sterile normal saline for the material you were injecting into your fellow students. And the these are multiple use. Ampules can be used once because you have to break them open. They're exposed to air. The seal on a vial will keep a lot of contamination out. There's usually a um, there's usually a protocol in place, no matter where you are, as to how long you can continue to use any multi-dose vial. It depends on the facility. It could be a week, it could be a month, but your facility generally will, after a certain period of time, not allow any further punctures of the septum, the rubber membrane um, that you have to go through. So this is what an ampule looks like. We shake the ampule, knock it around a little bit, um, and and get everything out of here down into the body. We break this off, and at the neck here, withdraw the contents. Um, I prefer to use a needle with a glassine filter in it because we don't know that there aren't going to be particles that fall into this ampule when we open it up. Um, the and this is a smaller one, slightly different design. Usually it gets broken here. I usually will use something like a small file um, and score where I want to break so it's a cleaner break. And then you simply snap it, being very, very careful not, of course, to injure yourself. These are examples of vials. Bacteriostatic sodium, 0.9% sodium chloride or normal saline, means that it has a preservative in it so that we can puncture this multiple times. Smaller ones are generally single use, or they may contain a powder that we have to inject some diluent into. A diluent is anything that we use to dissolve something. Um, so parenteral medication generally refers to um, the injection of liquid drugs into the body or liquid substances. It can be things that aren't formally drugs, like normal saline or D5W, 5% dextrose in water, via a sterile needle and syringe. Um, you've already been through syringe technique, so you know that we use them and they go immediately into the sharps box. Um, and we rotate the sharps box out when it's full. It can be a liquid or a powder that is first reconstituted or dissolved in some liquid that is listed on the label of the product as being used for that product. Some products um, will not dissolve in things like normal saline, or they'll dissolve and immediately precipitate back out. And so we can't use them. So we have to use something else, maybe D5W. Um, so we have muscles. We have intramuscular route, intravenous, which is directly into the venous system, under the skin. We have subcutaneous. The spinal column is often called intrathecal. This is the epidural that many women are very aware of. Um, Intradermal injections, if done correctly, you'll get a wheal or a little bubble under the surface of the skin in the area that will ultimately resolve, but it'll stay for a little while. We use short, high gauge needles because we're going in at a very narrow angle and we're going in a very specific location. Um, The forearm can be done, the upper chest and back can also be used. Um, Skin tests for allergies are common. If you work in an allergist's office, you may find yourself doing a lot of these. Um, so here's a picture of what it looks like. It goes between the epidermis and the dermis and actually goes in slightly further than that. I like to take up about half of the needle length, doing a an intradermal. Subcutaneous is below. If we look up here at this picture, this is the subcutaneous tissue is down below the dermis. So so subcutaneous are given um, in a number of different areas of the body. Around the belly is common. Um, Deltoid or the back of the arm where we have a little bit of fatty tissue in between muscles. Um, there are places on the chest and the upper back, upper chest and upper back. We go in at a 45-degree angle, except for insulin and heparin, which we go in at a 90-degree angle. Heparin is a blood thinner. It's an anticoagulant that's often used post-surgically. Subcutaneous, so here's a picture, goes down into and actually down into the subcutaneous layer. We generally will go the entire length of the needle. It's generally a bit shorter than an intramuscular. It can be 5/8 of an inch, and that's what I generally use. IM injections, many places. It can be the deltoid, it can be the gluteus medius or gluteus maximus, the vastus lateralis on the side. in adults. Um, and that's the route usually used for infants because the rest of their muscles are too small. We want drugs that we need more rapid absorption. We use again a 90-degree angle, um, a half a milliliter to 5 milliliters. Well, 5 milliliters just about always has to go into the gluteus maximus. No other muscle has the mass to be able to take that volume. Um, so here we have gauges from 20 to 23. A lot of times that was because the volume was a bit higher and because drugs tended to be more viscous. More modern drugs tend to be much less viscous, not thick. Basically, the consistency of water, so that we can use actually a smaller gauge, a higher gauge or a smaller diameter needle. So it goes directly into the muscle at a 90-degree angle. Z-track comes and goes. Z-track is used when we don't want the drug to leak out ever, and when it can be irritating to the skin. So what we do is we literally pull down on the skin. Okay, I'll demonstrate. This is a forearm, so it's not a great example. But notice if I pull on the skin, I'm actually displacing the skin so that if I go into the muscle here, do my injection, and then let go, then the various layers basically come and you're looking at um, a break in that puncture hole. So the adipose tissue, the subcutaneous layer, then displaces the back over the hole in the muscle and keeps the drug from leaking out. This is especially important for thicker drugs too. IV is not necessarily used during emergency situations, although it often is. The we go into some sort of superficial vein. It can be a hand, it can be an arm, it can be a foot, it can be whatever is available. It can be, in some cases, it'll go into like the subclavian vein or one of those. Usually superficial, but not always. Basically, the drug is circulating within 2 minutes. That's about the amount of time it takes for blood to circulate, make one pass through the entire body. It goes straight in and all of it's there. We have pumps. Don't have pictures here. You've seen them. You probably have seen them in the facility you work in. Pumps are often used to give what we call continuous infusions. Um, they can be used for to force very carefully measured amounts into veins over time. We also can use static systems that use gravity as the pressure that pushes a drug into the body. Um, we also have pumps that we can install for diabetic patients. So we can these are diabetic patients that are not easily controlled on either drugs or insulin. Topical, we talked about that. We put them on. We have lotions, liniments, ointments, and then the transdermal patch. Um, and creams also can be used for this. Um, they're mostly for local use, although transdermal patches can be used to deliver drugs systemically. It's absorbed through the skin, so we're losing transdermal. We've got nitroglycerin. There are estrogen patches and testosterone, nicotine patches for people who are trying to quit smoking, scopolamine patches for motion sickness. We now have fentanyl patches for delivering low levels of narcotic to patients under pain stress. Inhalation is another route. Inhalation is the act of breathing um, the drug as a vapor or a powder, dry powder, into the lung, and they can provide local effects in the respiratory tract, or they can be used to deliver drugs to the entire body. Inhalation is done. Oxygen is the most common inhaled gas that we use, and usually you'll see it described as liters per minute that they go in. A liter is about a quart, um, with a high oxygen concentration. We have concentrators, and then we have oxygen bottles that we can source the oxygen from. We have, when we're looking at inhalation, the most common of these medications are the bronchodilators and the steroids used for asthma. And when we have patients that are having problems with high mucus production that are clogging up their lungs, we have some agents we call mucolytic agents that we can put in by inhalation. We found this out the hard way, of course, with a bunch of newborns. We found out that it's not a good idea to give inhaled oxygen to newborns. Now, drugs can be put in through other places, the eyes, the ears, the nose, etc. We can put things into the eye. These things are always sterile. We say that they're isotonic, which means isotonic means that it has a concentration of dissolved materials, salts and proteins and other things that mimics the fluid that would normally be in the eye. So isotonicity minimizes irritation, and which we interpret as burning to our eyes. So we have antibiotics, we have decongestants, we have topical anesthetics. Your ophthalmologist or optometrist will use a plant-based product, an atropine product, an extract of belladonna, to enlarge the pupils so that they can do an eye exam. Careful administration of ophthalmic needs to be with the patient with their head and face facing upward. They can be lying down or they can be sitting in a chair. It doesn't matter. But we instill it. We usually try to expose the lower part of the sclera by pulling on the bottom of the eyelid gently. We just pull right below the eye and pull it down. Otic is ear. Again, we have low doses. Obviously, we don't want to use it if the eardrum is broken, because then these things are generally only used externally in the external part of the ear. And again, we can squirt it in using, this is you can see here, a very blunt tipped ear syringe. Nasal, we can put things into the nose. People do this. We have, nasal saline. We also have nasal drugs for clearing up nasal congestion and sinus infections and that sort of thing. So the nasal route is something, again, the head has to be tilted back. Here's a good example of when someone should be lying down with their head over the end of the table. Vaginal route, local infections can be treated with all sorts of things. We can use suppositories, even tablets. creams, foams, and that sort of thing that can be either inserted by hand or using an applicator. This usually requires a little bit of training to the patient. Rectal route, we talked about nausea and that sort of thing, but also if a patient is unconscious, you don't put things in their mouth. And so we basically insert the rectal suppository and have the patient lie for at least 15 minutes on their side for absorption. Okay. There are lots of places to get drug information. And here is a list of some of these. There's something that right now, I love the internet here because if you go in and type a drug name in any internet search, then you can find you get a tremendous number of hits. There are some other handbooks. The most common ones that we use are the PDR, the Physician's Desk Reference, which is really a collection of all of the product labeling. It's a good source of information. It's available online as well. The Orange Book is the FDA's list of drugs that are approved for use. The U.S. Pharmacopoeia National Formulary is another source of good information about drugs, and especially if you have to do compounding, in other words, preparing a different dose than is commercially available for a product, then you can usually find the recipe in the USP. There are others here. One that is not, one that you should be familiar with is the Pediatric and Geriatric Dosage Handbooks, because patients, very young and very old patients, handle drugs differently and require different doses depending on their conditions. One thing that's not here is something that you should put on your smartphone, which is Epocrates. And Epocrates is a great source of drug information and other medical information. You can get a downloadable copy for free onto your smartphone. And then when you're actually out there working, you can upgrade to the paid version. So that's what I was going to say about that particular chapter. Let's get out of that. And I'm going to take a short break. So it is almost 8 p.m. I hope you're going to be able to get on tonight. So I'm going to pause the recording. Okay, Kat, when you look at this video, I want you to send me an email with the word Penang, P-E-N-A-N-G, in it, so that I know you have actually listened to this video. Okay, I hope you get on before I get finished, but I want to talk about this week's discussion topic, which is about the risk of drug and food-drug interactions in hospitalized patients. So let's look at some of the material from chapter 10, which is about that topic. So let's go back. So we'll wait for this to come up. Um, the issue about drug and food drug interactions is that they're very, very common. Drugs overlap in their activity, they work with, against, and aside from each other. They can uh, combine to make very great problems for patients, or they can combine to provide greater value to the patient. It all depends on the drug. So we're looking at drug actions and interactions. So what I want to do first is make this full screen. Okay. Part of the problem is that many patients are on multiple drugs, and it is hard to predict what those interactions are going to be. We know that drugs interact. We know enough about a lot of drugs to where there are certain combinations that are generally felt to be broadly safe, and safe is always a relative term. There is no drug that is truly safe, but broadly safe to be used in combination because they have been used and studied um, a great deal. But that is the problem, is that some people are on many drugs, and so the more drugs you are on, the more likely you're to have problems. And another issue is that in medicine, there is a tendency to put people onto a drug. The drug has side effects. One of the possible side effects of many antidepressant drugs is Parkinson's-like symptoms, the tremors and so forth that are typical of Parkinson's patients. So the doctors will put people on an anti-Parkinson's drug when they don't have Parkinson's disease. They have a drug reaction instead of changing the drug. So, and then Parkinson's drugs have their side effects. And so pretty soon we're prescribing drugs to treat the side effects of the drugs we've prescribed. So there are some, and then there are interactions there as well, that can sometimes be fatal. So we can talk about that topic quite a bit, but I'd like to talk first about what happens, why this happens. Drugs are there are a couple of sciences. One is the science of pharmacodynamics, which is the science of what the drug does to the body. So, for instance, the patient is on warfarin, Coumadin. What that does to the body is it interferes with the vitamin K mediated step of blood clotting, and prevents the blood from clotting. Well, interfering with that does have its side effects, and it means that we have to be very careful that nothing else that the patient is taking will either make the anti-clotting more potent and therefore lead to bleeding, or will actually interfere with the ability of Coumadin to do its job and lead to clotting instead. So there are lots of things we have to think about. And what we want to be doing is looking at how the body deals with drugs, because this is one of the major sources of drug interactions. And this is the science of pharmacokinetics. And pharmacokinetics looks at multiple steps in the life of a drug in the body. First off, the drug is absorbed. Whether that drug is administered by injection or orally, the absorption step may be different, may take longer, but nonetheless, the body does absorb it. Then it's distributed throughout the body, and then it's metabolized or changed. We hope that in the distribution phase, it goes to where it needs to be. But metabolism is where the body changes the drug and prepares it for getting rid of. The body doesn't like drugs. The body has mechanisms for detoxifying, which is an interesting thought when you think when you're talking about drugs. That means that the body recognizes them as toxic. So the body wants to get rid of them. So it metabolizes the drug, and then the last step is excretion. It puts them out of the body. The main metabolic organ is the liver, although the kidney will do some metabolism, and some other tissues in the body will do a bit of metabolism, but mainly that's done in the liver. And that process changes the drug, and then it goes out through, generally speaking, through either the urine, which is the most common method of getting rid of drugs, or the feces. Now, it can go out through the lungs as a gas, but those are pretty rare. It can even go out through the surface of the skin with sweat, but also pretty rare. Mostly they're going to come out of the urine. That's why all of our drug tests are urine based, or most of them are. So, but the drug can also be excreted through the colon as part of feces. So these 4 steps are critical. So here's a good graphic showing the drug being absorbed, a drug being administered, okay? Either orally or through injection. When it is taken through, taken in through the mouth, it goes into the stomach. If it's injected, it immediately gets circulated through the circulatory system. And then there's 2 steps. Orally administered drugs will first pass through the liver, where that will be the first place of distribution to the body. And then it will go into the bloodstream and be distributed again throughout the distributed through the body, and then pass back through the liver regularly, where it is continually metabolized. When the drug is injected, it ultimately will get to the liver, but most of it's just not metabolized out as quickly as oral drugs. And then it's excreted either through the colon or the kidney. Absorption is from the site of administration into the bloodstream. So for an intramuscular injection, the drug is absorbed out of the muscle into the bloodstream. For a drug that's put under the tongue, it's absorbed into the oral mucosa, straight into the capillary network in the bloodstream. Diffusion is the next step. It moves from various areas where it's in high concentration and distributes itself out and equalizes the concentration in the body. And here we also have during the process of absorption, we have the first pass effect. Oral drugs then get partly metabolized in the liver right away. In fact, you can lose 20 to 80% of that original dose. Distribution is when it leaves the bloodstream and enters the tissues, hopefully where it needs to be, but often they're generally distributed throughout the body. And the rate is dependent on the perfusion that each of the various body systems has with blood. Metabolism, they're generally transformed by a process that we call biotransformation, which means the body chemically modifies the drug often, not always, but often, chemically modifies the drug to make it quicker to be disposed of through excretion. In the liver, there is a whole enzyme set of systems that we call cytochrome P450. There are many P450 enzymes, and different drugs are metabolized by different of those P450 enzymes. And then once they are metabolized, they're excreted. As we said, the kidney was the major place, but it can be through a lot of things. We see here mostly in the urine, then feces, saliva, sweat, breast milk, and obviously in lactating women, breath and tears. Then we look at, so this is an issue when we're looking at one of the major issues with drug side effects is impairment of the liver systems that metabolize specific drugs. Going back to Coumadin, which is metabolized by one of the subsystems of P450 in the liver. If you'll see a warning label on Coumadin and a number of drugs that people should not eat grapefruit or drink grapefruit juice or that sort of thing if they're taking these drugs, or a supplement that a lot of people use called St. John's wort. And that's because those drugs interfere with that particular branch of the P450 system that metabolizes Coumadin, and you can get a buildup of the Coumadin in your system, causing bleeding, spontaneous bleeding, and it's a major issue. So we have that, all of that. The metabolism is one of the things that is often most interfered with in drug interactions and drug-food interactions. I said that pharmacodynamics was the study of the effects of drugs on the body, and sometimes the drugs have an affinity for certain types of tissues or cells, and it will attach to those cells through some sort of receptor. A receptor is a molecule that actually will latch onto the drug and will then, in the process of being attached to by the drug, it will then change its form and actually exert a biological effect within the cell. So we have another term that we use, agonist. This is the drug that has the specific affinity for this receptor. So here's a graphic of how drugs can work. We have a cell, we have a receptor molecule on its surface, we have drugs that have sites that can and cannot bind to the drug. These two are sites. If you look at these two little points of attachment on this drawing, these two will not fit, but this one can bind. It's the agonist. So that's how this works. The active the binding is in a place we call the active site for the drug. We have the concept of half-life, which is the amount of time needed for the maximum concentration of a drug to be reduced by 50%, and then a further 50% and a further 50%. So the mantra in medicine is that 10 half-lives means there's no drug measurable left. So if you think about that, we've got half, a quarter, an eighth, a 16th, a 64th, 128th. By the time we get down to 10 of those half-lives, we've got less than 1/10 of 1% of the drug left in the body, in the plasma. So there's another term you'll run into is bioavailability. That is the total amount of drug that actually gets into blood circulation after administration. So for an oral drug, It'll be what's left after that first pass metabolism. For an injectable drug, again, we generally consider them to be 100% bioavailable. Body rhythms, diurnal rhythms, in other words, during the day, will affect drugs. There are certain drugs that you don't want to take at various times of the day. You wouldn't want to take a sleep aid at breakfast, for instance. You wouldn't want to, and in fact, when you are taking many medications, they will specify that many drugs are taken once a day in the morning. And this could be before food. For instance, the most prescribed drug in the United States currently is levothyroxine for poor thyroid function. And you are supposed to take that but when you get up in the morning and before you have any food, at least half an hour before eating, to be able to absorb that drug. Um, there are many studies on the concept of psychological factors that will affect the way drugs work in the body. There's the placebo effect. In which a patient will tell you that they're having an effect of a drug when they're not receiving the drug itself. Placebo is commonly used in our clinical trials as a way to have a way of comparing a patient known not to be receiving the active drug to what happens to a patient who actually receives it. And an amazing amount of time of the times we find that people will respond to placebo. We also call those sugar pills, but it's basically a simulated medication that doesn't have any drug in it. So people who actually believe that they're getting the drug often will, in fact, respond to placebo. It's a very well-known issue. This is very common in psychoactive drugs, antidepressants, anxiolytics, and so forth. On the other hand, if the patient thinks they're getting better, what's wrong with that? Toxicity, drugs are required to be both safe and effective in treating patients, meaning that there will be very few side effects at what is supposed to be an effective dose. And we call the difference between a therapeutic dose and the dose at which we see toxicity, the therapeutic index. Okay, and we have certain things. An LD50 is a dose that will kill 50% of animals. We don't like those. The effective dose, or ED50, is a dose that will produce a specific therapeutic effect in 50% of the animals tested. Now, notice I said animals. We measure these things in animals. We don't do LD50s in humans, or LD10s or LD1s for that matter, meaning LD50 is a dose that'll kill 50%, and LD10 is a dose that'll kill 10%, and an LD1 is a dose that might kill 1% of animals. This is actually, as much as anything else, a measure of the variability between individuals taking drugs. Drug effects, there are side effects and there are adverse effects. The difference between side effects and adverse effects is severity. Adverse effects have more severe symptoms, ranging up to death, which I think everybody would consider was pretty adverse. Causing liver failure also would be considered adverse. And then there are unique, unpredicted reactions that individuals can have. These are called idiosyncratic, and they mean individually seen and not explained by mechanism or anything else. Usually we think of these as things that happen from a genetic difference between individuals. We have allergic reactions that can range from what we call hypersensitivity reactions, which are unpredictable. And this is actually after a drug is received, after a patient's received a drug, they will start developing antibodies and respond with a hyperactive allergic response. One of the most common of those is penicillin allergies. And we see a lot of people who are allergic to penicillin, and they can be their reaction can range from hives and itching, basically an unpleasant experience, all the way up to not being able to breathe and what we call an anaphylactic reaction, in which they produce an overwhelming range of antibodies that start attacking body systems and can be fatal. Um, so we want to be on, that's why you'll find every drug has a notation that says if a rash develops or if you get some sort of other symptom, they will tell you to stop taking the drug and call your doctor immediately. Because the thing about allergic and hypersensitivity reactions is that they get worse the more you take the drug. So you want to stop that immediately. Here we're talking about the slide about the anaphylactic reaction. And this is a true medical emergency. This is something that this is why some people carry EpiPens, for instance, um, to, to, to get over that, to be able to rescue from an anaphylactic type reaction. Um, drug interactions are um, the interference of a drug with another drug, or a food, or possibly even some laboratory test. And I'm thinking specifically of, say, an injectable dye for a contrast MRI or CT. Usually, uh, these come from taking more than drug concurrently, but more than one drug concurrently. But it can happen with taking only one drug and then eating a food that causes it. And it can occur anytime during the pharmacokinetic profile. So there are several different types of interactions. Synergism means working together, two drugs that will produce a stronger effect um, than either when taken alone. They're not additive, so it's stronger than if you the sum. This is a case of the sum is greater. The whole is greater than the sum of the parts. So the combination of warfarin and aspirin is very, very dangerous because both of them interfere with blood clotting. Potentiation is when one drug increases or prolongs the effect of another. Sometimes we will use this. Potentiation is important in the use of the Tylenol with codeine type products. The codeine prolongs, or the Tylenol prolongs the effect of the codeine. Sometimes it's useful to build up, to quickly build up a drug level. Um, the example here is when cimetidine, which is Tagamet, is combined with asthma meds containing the drug theophylline. We get a prolonged effect on the anti-asthma effects of the theophylline. Antagonism is when they decrease the effects of each other. Um, Tetracycline and antacids are a good one because the tetracycline is absorbed in the stomach, and the stomach has to be acidic for proper absorption of TET. So, or when ibuprofen and aspirin are taken together, and God knows why you do that, both of them irritate the dickens out of the stomach, but they stop each other's actions. Multiple effects. Many drugs have multiple effects. Um, and they are and some of those effects are desirable and some are not. Um, Patients that have severe um, um, CNS diseases might be taking an antipsychotic, an antidepressant, and possibly, we talked about this before, an anti-Parkinson drug uh, for the side effects of the other two. But all of these have what we call an anticholinergic effect, which interferes with another biological pathway, and that additive effect can be very negative. Um, One other problem is multiple prescribers. Uh, the the When you go to multiple physicians, and it's imperative that you tell any physician you see every drug and supplement you take, so that they will know, have a better chance of giving you a drug that's safer for you to take. Um, there are lots of examples of this. The one they're giving us here is the mix of anti-anxiety and antihistamines might cause depression, um, uh, an excessive effect of depression. So um, multiple physicians are doing that. One of the advantages that even when people see multiple physicians, they often go to the same pharmacy. So the pharmacist has a chance to observe what they're taking much more directly. Um, Non-prescription and supplement use, they all have some effect on the body. All of these things potentially can interact with drugs. And those interactions can be any of the ones that we've seen, or they can be, as I described before, they can interfere with the way the drugs are metabolized. But they can cause potentiation, synergy, or antagonism. So we want to be very, very careful that we are uh, that we are that our physicians are cognizant of everything we take, even that morning baby aspirin that many of us take to reduce the risk of stroke, or the multivitamin. We just really want to, the doctor needs to know exactly, because these things can interact. Non-compliance, lots of ways that patients can be non-compliant. Um, some of it is deliberate. They will decide they don't like the drug, and they'll simply stop without saying anything to their physician. The physician, assuming that the patient is still taking the drug, then wonders what's going on. And if the patient is not passing that information along, then there's a problem. They may be confused about dosage instructions. This is something that both the medical practitioner and the pharmacy should be making certain the patient knows. And the worst question you can ever ask is, do you know how to take this drug? The answer is always yes, whether they know it or not. So you just pretend they don't know and tell them. They forget to take, especially if they have lots of meds that they take at different times a day. Forgetting to take medications is a major problem. And the more medications you take, the less compliant a patient gets. Other patients may make the mistake of doubling up a dose if they have failed, if they've missed one. That's not a good idea. All these things say if you miss a dose, don't double up, but people do it anyway. And this can cause toxic reactions. Um, Drug abuse is a totally different subject. A lot of drugs are addictive and have high abuse potential. Barbiturates and amphetamines are all part, and opioids are all part of the DEA Schedule 2 sequence, where they are listed as highly addictive but have a medical use. Um, Certain other analgesics are a part of that as well. But then there's the patient themselves. Age. The very young and the very old treat drugs differently biologically. There are genetic factors. Everybody is a little different. And so this is why we worry about, well, we don't worry, is why we're cognizant of the things that I was talking about, the idiosyncratic reaction. Um, whatever diseases a patient has. Let's just say a patient has liver cancer. Liver cancer interferes with the ability of the liver to process drugs. Any liver disease, cirrhosis, there are liver infections of varying types. The hepatitis, what we call all of those will interfere with the ability of the liver to properly metabolize drugs. So there we have there we will see effects on these drug interactions. The patient's diet, you know, do they have a good diet? Do they have a diet that is putting stress on various organ systems in the body? Alcohol changes the way the liver processes drugs, changes the way the kidneys function, changes the way the heart functions, um, and certainly changes the way the brain functions. Smoking is the same way. Smoking will interfere with the metabolism of some drugs. It will also accelerate the metabolism of others. Alcohol consumption in small amounts sometimes will actually accelerate the metabolism of drugs, but in large amounts will interfere with liver systems, as we know. Okay. Okay. So here we have a couple of things related to age. Um, the young and elderly have increased adverse drug reactions because they're given doses that are inappropriate for them, or they're given drugs inappropriate for them because they can't handle them. P450 um, um, uh, will isn't functioning real well in newborns, but by the time you get up into your 60s, 70s, 80s, you've beaten your liver up pretty well. And a lot of times, and it's the same thing. Patient illnesses, elderly have they lose renal function. They lose again. They've beaten up their livers, so they're not doing well with those either. Genetics um, can interfere with a lot of different um, um, can cause a lot of different variation from patient to patient. Not just making them more prone to being allergic, but in those idiosyncratic reactions. Okay, there's an example here with isoniazid. Um, can inhibit phenytoin, which is an anti-seizure drug, and cause all sorts of problems. Renal and hepatic disease will certainly influence patients. Diet, the food we eat. A lot of antibiotics are supposed to be given an hour before or 2 hours after meals because they need to be on an empty stomach. Others need to be on a full stomach. We look here and see all sorts of things. Grapefruit juice um, interacts with all manner of drugs because it affects a major section of the P450 system. Okay. Um, we all know that um, monoamine oxidase inhibitors that are used for treating depression, toxicity rises with in some people who drink wine or eat cheese or yogurt. CNS drugs CNS stimulating drugs, if combined with caffeine, can cause a problem. We have uh, diuretics, potassium sparing diuretics, and salt substitutes can lower blood potassium levels. Blood potassium and sodium are in blood. They are what we call monovalent cations. Sodium and potassium are balanced, very carefully balanced within the body. The major extracellular ion, monovalent cation, is sodium. The major intracellular is potassium, but they can exchange, and that ratio is critical to health. Okay, we talked about alcohol, and we all know that alcohol and depressants can lead to death. Smoking can increase the activity of drug metabolizing enzymes, and that can decrease the effects of a lot of different drugs. So we have to look at all of these things, and this requires for you as a future medical assistant, you need to be able to take a very, very accurate patient history, including their drug history. And we need to be aware of the major problems. As a medical assistant, you're not going to be doing a diagnosis of patients, but you want to know the questions to ask. And you need to get that information down. And when something looks to you like something the doctor needs to know, you need to be able to, for sure, point that out. Okay. And so part of what we do with patients that have risk factors like age, medical condition, et cetera, is look at therapeutic alternatives. We need to avoid complex regimens. That's easier said than done. Some patients are on so many medications that it's a miracle they can even get up and walk because they're medicated into almost catatonia. And also, patients need to take an interest in their own health. So that's what I wanted to say here. Then let's go back and look at. Let's shrink this and go back and look at um, the discussion for this week. So the discussion here is to look at what goes on in hospitalized patients. Think about this in terms of a hospitalized patient um, is generally someone that the hospital staff is not terribly familiar with. Even patients, even people that have been in the hospital multiple times, the staff they're going to be dealing with don't know them. They don't know their medical history that well. It's all in their records, but you can't expect them to read all that. We also have food allergies, and they flat out make mistakes. Um, we have there are lots of examples of patients going into a hospital um, or going in for medical treatment and being given the wrong drugs or drugs that they should have known not to. And so what we have is we have patients that are already compromised. They're already sick. If they've gone in for surgery, they've been put on multiple antibiotics. They've been put on blood thinners. They've been put on all sorts of drugs for to make sure that they don't develop complications after the surgeries. And then there's the kitchen. The kitchen doesn't know what the patients can or cannot eat. Now, there's supposed to be dietary recommendations, but again, we're dependent on the doctors and the people who are setting things up knowing that. Okay. So the next thing is to look up um, an article in a medical journal or on a drug information website, and there are plenty of them, that involves one or more patients experience a severe drug interaction. Okay, look at the article, research this, and look at how this patient was affected by these drug um, or drug food interactions, and make sure you cite according to the guidelines we use. The instruction here is to use our institutional writing guidelines, but quite frankly, the citation guidelines for that are not significantly, not in any way that different from APA. So just stay with your APA stuff. That's what you'll probably be using. Now I have my first post here, and I have some discussion and an article I found. It would be really interesting to see what you can find. I guarantee you there are plenty, and it shouldn't take you very much work to find one. Remember, if it's in a journal um, and you can't access it on your own, go through Shark. Go through our library. We have subscriptions through ProQuest and through all the other databases that we have licenses to, and we can get all of those articles. So don't forget that. You don't have to say, oh, I couldn't download it, because if you go into our system, you can generally get what you want. What you can do, however, and to make it easier, is when you find something that you can't access, get the identifier information. There are several of those. The identifier information can include things like what is called a DOI number, digital object identifier. It's a good way to search in Shark or Sinhall or any of the other databases for a specific article. The DOI number is very, very specific to each and every article that has an assigned DOI. Also, if you can't find a DOI listed, just the name and the date of the publication and the name of the author can help you find those. So the searching of that information is pretty easy. If you have trouble, get some help. Laura is always available in the Success Center. You can contact me, but quite frankly, we're swamped, and that's actually a pun because our basement flooded last week. So we are up to our ears in trying to fix that mess. So I probably will not respond real fast to any email that you send, but I will try. And I know that your work schedule, I don't know what your work schedule is tomorrow, but we'll you can contact me if you want, or Laura. She's a big help. But let's get started. So, other than the discussion, let's go back and take a look at the assignment. The week one assignment is to go ahead and get the workbook pages for chapters 5, 10, and 31, which you can get. I'll take us back here. You can get them in the readings and tools page in each week. You note here we have the workbook pages, and I'll show you one that I downloaded already. That's not right. Where did that go? Okay. Yeah, there it is. So here is what that looks like. It's 8 pages. There's material here um, beside what, yeah, that's fine, I don't care. There's material here beside the questions, but there's a summary of the material we just covered in chapter 5. Yeah, they're having a hard time just working fast. And then there's a series of questions. So just like with just like you did with I think with Com 103, you'll be filling this out, and then you'll take that and use it to answer the questions in the assignment. So wait a minute, I did not. Let's do this. It's a new share. Sorry, this is what it looks like. You've got questions. Actually, you won't see that mess. That's a screen issue for me. But it's a summary of chapter 5, and then we get down here, and there it is. You've got questions. So here's matching the term and the definition. For instance, we've got an ampule, a sealed glass container that usually contains a single dose of medicine. Top must be broken off. So number 1 is D. There, you got one. So let's go back here. So you have workbook pages for each. So do those. And let's go back to here. So the assignment makes that clear. Here is no time limit on this. There's no reason once you do the worksheets that you need to do multiple attempts. So we'll go back here, and then we have an assessment each week. And I will change that to multiple attempts and no time limit. So let's go ahead and get started. Don't fall behind. We need you to stay current with this so that we can get through all of this without any trouble. And on Wednesday, we will do an in-class activity of some sort. If you have any questions, please send them to me or write them down and ask me on Wednesday. And I'm sorry you didn't get on tonight. There's the usual here of writing about yourself. I don't think you need to fill that one out. We've done a couple of things together already. So we don't have any other students here for you to talk to. So if you want to fill it out, that's great. You can tell me about some things about yourself that I don't know. And then I will see you. I'm going to go ahead and end this. I'm tired of talking. I will see you on Wednesday. I will also post this. Remember, there is a code word here that you need to send to me in an email. So I will hope that you will do that. So I will stop the recording